to thank Dr. Kanungo and his team for inviting me to talk at your conference today. Very, very nice to be with you all. I wish I could have been there in person, but it's not possible. Bhubaneswar is also one of the places I visit very often to see family and relatives from London, but maybe another time. So this is the title of my talk, Diabetes, COVID-19 and Mucormycosis, an Indian tsunami. It's such a grandiose title, but I think it's appropriate, and you'll see why. What I'll do is to discuss the incredible synergistic but evil interaction between diabetes, COVID-19, and the catastrophic effect that combination has in causing what has been regarded as a tsunami of mucormycosis infection in India. This is otherwise a rare disease, even by Indian standard. I will also describe how or what can be done to improve management and prevention of this dreadful condition, which has killed thousands of people, particularly in India. I came across this interesting article in the Hindustan Times, New Delhi, published May 21st, which says that mucormycosis, the black fungus, has infected at least 7,250 and killed at least 219 people in India. And there are the states there and the statistics, but the three biggest in terms of cases and deaths are respectively Maharashtra first, Gujarat second, and Madhya Pradesh third. There are some interesting comments in that article, and one of the things is that because of this tsunami of mucormycosis cases, which are classically treated with amphotericin B, the country is running out of supply of amphotericin B, and that every attempt should be made to procure a drug for mucormycosis from international sources. And I think the next one is interesting in terms it really summarizes that evil interactions gives rise to this catastrophic disease, which is that diabetes lowers the body's immune defenses, coronavirus 19 exacerbates it, and to make matter worse, the steroids used for treatment of coronavirus which is important because it controls the anti-inflammatory side of the COVID-19 pneumonitis, but unfortunately, because of its immunosuppressive effect, predisposes to infection, including mucormycosis, and it's like adding fuel to the fire. And then these are very interesting statements in that article. It says India is a COVID disaster, but it didn't have to be. There's anger about COVID in Modi's constituency. India's COVID-19 patients turn to black market and also over the counter to prescribe themselves. And that is one of the big problems, of course, in controlling such a dreadful infection. Then, interestingly, says a senior government official says there is no big outbreak, yet it is difficult to say why a growing number of cases of mucormycosis are being reported from all over the country. So, what is COVID-19 associated mucormycosis, or CAM? It's a notorious fungal co-infection that occurs with COVID, but very importantly, to realize it can occur during COVID for many weeks or months after recovery from COVID-19 infection. It accounts for about 0.3% of COVID-19 co-infections. It's been reported in many countries around the world, but India is the epicenter, with this alarming increase in cases of mucormycosis compared to other countries around the world. So during the first week of June 2001, India is reported to have had 20,000 cases of COVID-associated mucormycosis, abbreviated to CAM, and by far the hardest hit country in the world. And this is really nicely illustrated in the next global map of the world, and saying in India, all red, there's no other red country, so to speak. So just focusing then on the problem in India. Then prior to COVID-19, mucormycosis did occur, but it was rare even by Indian standard, although, not surprisingly, it's much higher incidence compared with developed countries, some 70 times higher the incidence, because of the humidity, the heat, and the tropical nature, which favors the growth of this fungus in the environment. So there was, again, more statistics. There was explosion of cases of CAM during the second wave of COVID-19. Is estimated that it's around 68,000 cases in total in India. As a result of which the government of India has declared CAM a notifiable disease, and indeed many state governments declared an epidemic. I think that was important because it required implementation of control measures, guidance in procuring amphotericin B and other agents to control the disease. What is very interesting is that in this particular scenario of diabetes and COVID-19 interaction, the form of mucormycosis that one sees is mostly that one which affects the sinuses and the orbit and eventually the brain, and that is called rhino-orbital cerebral mucormycosis, or shortened to CARCOM. And this is by far the most common type of mucormycosis seen during the pandemic in India, followed by pulmonary mucormycosis, with which you may also be familiar with. Mortality from mucormycosis has increased dramatically from about what was very bad already, 50% mortality rate pre-COVID, to around 85% during the pandemic, which is related, it seems, to lack of awareness, crowded hospitals, unavailability of health resources, healthcare resources, overburden, and in some cases unqualified, so unregistered healthcare workers, and poor diagnostic facility and quality. So let's just concentrate on this more common form that is in diabetic patients in COVID, CARCOM. The initial presentation is the paranasal sinuses, from which the infection spreads into the orbit and then retrograde into the brain, and almost always fatal, of course, in that particular situation. The cosmic study findings found that commonly is, as I've sort of explained above, is necrotic ulcers, black lesions, and hence the misnomer of black fungus, necrotic ulcers in nasal cavity, and in the eyes, the orbital apex syndrome, and then, as I said, retrograde spread to involve the cavernous sinus, causing cavernous sinus thrombosis, and the frontal lobe of the brain most commonly, and death. Ear involvement also happens sometimes, manifests as otitis externa, failing to respond to antibacterial treatment. The patient outcome, the increased mortality is with pulmonary cases, disseminated cases, and cerebral forms, which you can get in CARCOM, and of course, particularly in very badly controlled diabetes with high hemoglobin A1C level. In terms of risk factors for COVID-19 associated mucormycosis, or CAM, the most important is diabetes, but very importantly is uncontrolled diabetes. And that is reproducible in Indian literature, in at least about 65 to 70% of cases have uncontrolled diabetes. And it's also not just uncontrolled diabetes, it's the hypoglycemia from that, and sometimes the diabetic ketoacidosis. But these impair innate immunity, i.e. stability of granulocyte and macrophages to migrate phagocytose and kill spore of E. coralis and stop the infection from going any further. This mucorales other mucormycosis, interestingly, they possess a ketone reductase, and which enables it to thrive in high glucose condition in hyperglycemia, and results in a very poor prognosis. Interestingly, some statistics that in the almost 1.4 billion population of India, about 75 million, probably underestimate, 77 million with diabetes. And that is, so the control of diabetes is terribly important to the controlling COVID-19 as well as the COVID-19 associated mucormycosis. Very important contributing factor in this is the treatment of COVID with steroids, corticosteroids. And that is found again in around 70% of cases of CAN. But also, it's the inappropriate dose. Initial course in India, a very high dose of corticosteroids were used, which increased that risk even further. But that was recommended in the Indian guidelines to start with, and then reduced to be complied with the WHO guidelines later. And then, very importantly, also, non-severe patients who started taking corticosteroids out of fear and without sometimes consulting medical staff and going over the counter and getting the drugs and self-treating. And that no doubt contributed to this massive explosion of mucormycosis cases, of the black ones in India. It should be appreciated that corticosteroids cause lymphopenia and lymphocyte dysregulation, and hence increased risk of opportunistic infection, including mucormycosis, as well as inducing hyperglycemia in patients with diabetes. And the other treatment modalities in COVID-19 which is contributed to this is monoclonal antibodies. And obviously the one that was the most commonly used is tocilizumab. And obviously that is important in dampening down the inflammation and bringing COVID pneumonitis under control. But unfortunately, it also reduces immunity and increases risk of opportunistic infection, including mucormycosis. Antifungals, particularly voriconazole, which is inactive against mucorales, it can lead to breakthrough infection with mucormycosis. Inappropriate and over use of broad-spectrum antibiotics and antifungal in post-treatment prophylaxis interfere with the microbiome in the sinuses, and this possibly could increase risk of opportunistic infection as well as mucormycosis infection. Neutropenia, very well recognized risk factor for both bacterial and fungal infection, including mucormycosis, and organ transplant because it's use of corticosteroids and immunosuppressive drugs. Similarly, so, and that combined with poor infection control practices and environmental factors which are dominant in the Indian climate. So what is mucor? Because mucor is a very rare infection, as I told you. It's a fungus, it's a filamentous fungus. It's widespread in nature, it's ubiquitous in nature, being found in soil, in fruits and vegetables. And it is the cause of the disease mucormycosis, which previously was known as zygomycosis. Most common, there's so many mucor species, but the most common are the rhizopus, the mucor, the rhizomucor. And on culture, on Sabro plate, which is a fungal plate, the appearance is not a black fungus, as you can see. If anything, it's a white fungus. It's fluffy and it's powdery-like. That's because of all the filaments that's coming up and liberating, which then liberate the spores. And that's what you see on the right on a microscopic finding. There's all these long filaments, and there is this kind of sporing structure, which called branchiospore, which contains millions of spores, which are then liberated into the environment, into the air, into the soil, which obviously, when we breathe it in, come in contact, can germinate, produce hyphae, which is the invasive disease-forming form of the organism. And comparing Aspergillus, which is far more common than mucor, The mucormyces, they're much bigger. The filaments are larger, wider compared with Aspergillus. They also don't have any septi, unlike in Aspergillus on the left. You can see some septi there. And the mucobranches at a wide angle, 90 degrees plus, whereas Aspergillus branching is at 45 degrees, so-called dichotomous branching. So there are very interesting microscopic differences which can give a clue to the diagnosis. And here we're seeing in terms of the different forms of mucormycosis, how the pathogenesis, how they present, the risk factors. And I said the most common in terms of diabetes and COVID-19 is the rhinocerebral mucormycosis. And as I've said, it's the spores from the fungus, which gets into the sinuses and fades, and then goes through the cribriform plate and through also the orbit into the cavernous sinus, causing CST and eventually death. So it commonly manifests as ptosis, proptosis, permanent vision of loss, sinusitis, and so forth. The other forms of pulmonary mucormycosis and disseminated mucormycosis in terms of the context of diabetes. The disseminated form, which obviously is infection of the bloodstream and spread into different parts of the body, is particularly in iron overload situation. Iron is very important in a lot of microorganisms to grow, and that is also true for mucor, neutropenia, and immunosuppressive situations, but not necessarily diabetic ketoacidosis. Very important in mucor is angioinvasion or vascular invasion. This is the hallmark of mucormycosis. And it is this which leads to ischemia, necrosis of infected tissue, death of the tissue, causing black lesion. And that is what people have latched onto, or the media has latched as black fungus. It's not black fungus, it's the disease that manifests as dead tissue, which is black. But it impairs the delivery of immune response as well as antimicrobial therapy. That's why it's so difficult to treat when it is established. And of course, it contributes to hematogenous spread in the bloodstream to other organs. The glucose, there's a glucose-regulated protein receptor, GRP78, on endothelial cells, to which mucor can attach to and does attach to, and then invade as a mechanism by which it invades both the blood vessels into the bloodstream and also into the tissues. And this is a very nice pictorial explaining the pathogenesis with the environmental source of the organism, widespread soil, decaying matter, the right condition, which helps it to germinate. And with that, we must not also forget building constructions are a big place for this, because there's a lot of demolition, a lot of soils, a lot of air, a lot of soil, dust being generated. And these are rich sources for the fungus and its spores, which gets into healthy host, doesn't cause anything because we're very, very competent and intact innate immune mechanism with neutrophils and macrophages which gobble up the spores and prevent it from germinating to hyphae, which is really pathologic form of the organism that invades and causes so much destruction. However, in COVID patient, you have double whammy. You've got COVID, which can directly affect the innate immune system. Then you've got is indirectly through the treatment of COVID, as I've said, things like the corticosteroids, particularly impairing the innate immune mechanism and allowing the spores, the mucormyces spores, to germinate into hyphae, invade, and cause disease. And this is, again, this is saying that GRP78, the essential receptor for mucormyces, to latch onto and then invade into the bloodstream and into the tissues, and then spread, because the dreadful disease that it does. So the problems with mucormycosis is a rare disease. It's not very often thought about, and it's difficult to diagnose. difficult to manage, high morbidity, mortality, as I said, and it requires urgent and repeated surgical debridement often. So as a result, of course, there are clinical guidelines to help us manage mucormycosis, which deal with the whole spectrum of epidemiology, pathogenesis, clinical presentation, diagnosis, treatment, and prevention. There are international guidelines, and there are India-specific or India-centric guidelines. And I think both are important. I'm just saying in the international guideline, this is from the European Confederation of Medical Mycology and the mycosis study group, which is widely used globally. But as the India-centric guidelines are very good as well, and it's really tailored very much for COVID problem, for COVID-associated mucormycosis problem in India. The diagnosis, again, I've told you about the hallmark intravascular invasion, the black eschars, the lesions, necrotic black lesions. So we need a biopsy of the tissue. We need a tissue sample for microbiology to do microscopy and culture on fungal plate. If it doesn't, then we can do molecular diagnostic looking for the fungal DNA by 18 PCR. Also, because if you do grow the organism, we need to know what antifungal drug is susceptible to help manage, to treat this condition. But that usually is done in reference laboratory and takes a lot of time, at least a week or two. Then, of course, histology using H&E and fungal stents like PAS or GMS to go more remote. Silver stain stains the fungus black, and here is again the mucormyces with its aseptate hyphae and broad branching. And then these are, of course, the clinical presentations I think many of you become aware of in India, in far more cases than I have seen in London in my hospital. I'll be lucky to see no more than 1 or 2 cases a year, but you probably see hundreds. So you are far more expert in this than I am. But this is what these are the black lesions and the things. Black fungus is really the pathology that creates this black appearance and ischemic necrosis, and it's devastating. Here is the nose getting eaten well. Here we've got the palate being perforated and going through the peripheral plate, then into the frontal lobe of the brain. And in this particular case, you can see the CT MRI scan of intensive hemorrhage in the frontal lobe there, and also this is from a patient who died. And here is the orbit affected, and this requires urgent surgery. In most cases, the patient will lose that eye. But it can also, of course, invade across to the other side and cause double blindness. So this is absolutely catastrophic and very frightening, because there is really not much you can do in many other cases. In terms of antifungals, if you see unlike the Aspergillus and Candida, the Zygos here, Zygomyces, which is same as mucormyces, you can see is very resistant to antifungal drugs. The only thing is sensitive to are only about 3 drugs: amphotericin B, voriconazole, and recently in the last 5 years, isovoriconazole. So in terms of the treatment, by far the most important is not antifungal, it is surgery. Surgery is absolutely critical and it's urgent. You must do it quickly, and so be aggressive surgical debridement to get rid of all necrotic tissue until you can see bleeding tissue, healthy tissue. It may have to be repeated multiple times, but you do need antifungals as an adjunctive treatment to surgery, not as a replacement for. The primary agent, most effective agent, is liposomal amphotericin B, given at high doses, 5 to 10 milligrams, particularly for cerebral mucormycosis, the 10 milligrams. If you're intolerant to liposomal amphotericin B, one can use isovoriconazole or voriconazole. Both also can be used in an IV to oral switch, which is very useful, but unfortunately, neither of those are as effective as liposomal amphotericin B, which has to be given intravenously. Here, I just want to concentrate on the last 3 here in terms of the other modalities of treatment. Iron chelation, the study about mucormycosis thrives in the iron medium. The way it does it is It grabs the iron, free iron. In the blood, of course, iron is bound to iron-binding proteins such as transferrin. Diabetic ketoacidosis creates an acidic environment with a pH of 7.3 or lower. In that environment, when it decouples, the iron decouples, it comes away from the iron-binding protein and is freely floating in the bloodstream and in the tissues, which the maker grabs it. The maker has it, like desferrexin, for example, it can hijack it. But through that mechanism, it grabs iron, which helps it to grow and multiply. Sorry, the other thing is hyperbaric oxygen, but iron chelation there's no clinical trials. Neither is for hyperbaric oxygen. It's attractive, creating oxygen-rich environment, and it's not widely available. Similar with cytokine therapy, in vitro is active, but no clinical trials. It's very toxic and very expensive. So coming to the last couple of slides, the prevention of mucormycosis and diabetes. It's absolutely crucial to control COVID-19 and diabetes and reduce COVID-associated mucormycosis. So you need to check and through that, of course, the COVID control, you know that vaccination, masking, social distancing, hand hygiene, and so forth. But absolutely crucial is checking and controlling blood sugar level all the time. And keeping steroid use appropriate. Only patients who really need it, not i.e. those who are hypoxemic and seriously ill. Everybody takes it, and that is really contributed to the problem that we have seen in India and some other places to a lesser extent. And the dosage is very important, as I said, it's be at the correct dose and only for 5 to 10 days. And discontinue any type of immunosuppressive drugs as far as possible, because these are all contributing to allowing the fungus to multiply uncontrolled. Use a mask, and certainly that should reduce chances of inhaling the spores of Mucorales. Must avoid being near any construction site. And also, very importantly, once the patient recovers from COVID-19 discharge, must closely monitor for early symptoms, signs of mucormycosis, so including chest pain, respiratory insufficiencies, could be pulmonary mucormycosis, or the rhinocerebral intravascular blockage, excessive nose discharge, facial pain, eye problems, and so forth. So in conclusion, despite improvements in the last few years, survival from mucormycosis remains very poor. The overall mortality is between 40 and 80%, the latter more in the context of COVID and steroid, inappropriate use of steroid and immunosuppressive drugs, as well as monoclonal antibodies. Early aggressive surgical debridement system and antifungals are vital. And as I've said so many times now, controlling the risk factor is crucial. Diabetes, diabetic ketoacidosis, COVID-19, and this treatment, steroids, MC, monoclonal antibodies, including tocilizumab. So there's some references there, and there are references to international disease, and then India-centric, and these are really good articles. I would sort of encourage people interested in this disease and diabetes to read, and they're excellent, in fact. And there have been so many, but I've just chosen 3 of the ones I particularly follow, the ones I particularly liked. And with that, I thank you for listening. The question and answer session will follow in the panel discussion section. Just like to thank my registrar, St. Bart's Hospital, Dr. Anthony Batrat, who did some of the initial work when he presented, not this case, but on mucormycosis related to hemato-oncology problems in our journal last year, and also authors of the reference articles, because many of my illustrations are from them. So I'd like to thank them very much. And thank you for listening.